Hello, and welcome to today's webinar, Accelerating Imaging Workflows in Radiology and Cardiology, What Clinicians Need in 2026, in partnership with AGFA HealthCare. My name is Brian Casey. I'm managing editor of the Imaging Wire. Got a great program for you today. We're going to start with a panel discussion on shared enterprise imaging for radiology and cardiology. Then we'll open it up for questions in the second half of the webinar. You can ask a question at any time using the Q&A button at the bottom of your screen. Our webinar panelists are Dr. Alan Jansujwicz, a cardiologist with Northern Light Health in Maine, Dr. Yeang Chng, a radiologist with Spectrum Healthcare Partners, a radiology group serving Northern Light Health, and Stephanie Bazinet, Director of Ultrasound Solutions for Cardiovascular and Point of Care at AGFA HealthCare. Everybody, thanks for being with us today.
Thank you, Brian.
Thank you, Brian. Excited to be here.
Yeah, thank you for having me.
Yeah, so let's dive right into it. Let's start with introductions. Can you introduce yourself and describe your involvement with enterprise imaging? Dr. Jansujwicz, can you go first?
Yes, thanks, Brian. My name's Alan Jansujwicz. I'm a non-invasive cardiologist. I was the physician co-lead of the PACS Go Live with our AGFA EI. And I've been involved in informatics and PACS for probably about the last 10 years of my cardiology career.
All right, very good. Dr. Chung?
Hi, everyone. I'm Yeang Chng. I am a neuroradiologist by training, but pretty much read everything. And I had the honor of working with Dr. Jansujwicz as the other co-lead from the radiology side for the Go Live of AGFA EI, Enterprise Imaging Solution, which was about 3 years ago. So glad to be here.
All right, very good. And Stephanie, how about you?
Yeah, hi everyone. My name is Stephanie Bazinet, and I have been with AGFA HealthCare for about 11 years. I am a sonographer, and I support our go-to-market strategy and our clinical sales support here at AGFA. Nice to be here.
Yeah, perfect. Well, it's good to have you. Well, let's start with a little bit of background. Dr. Chung, can you talk about what your institution had prior to adopting this integrated enterprise imaging strategy, and maybe talk a little bit about what some of the challenges of that older system were?
Certainly, Brian. I've been with Northern Light Health for about 10 years now. And so for the initial part of that, we were on what most people think of as a traditional PAC system, with the older infrastructure where things were siloed. Things were very broken down to separate applications. For instance, our colleagues, Dr. Jansujwicz included, had a completely different interface, completely different, data silo for their cardiology applications. OB ultrasound similarly was in a different silo. And even for us in radiology, we had to go to several different applications to actually do a lot of our work. For instance, with PET imaging, we had to go to a different application. For 3D mammo, in many cases, we actually had to go to a different workstation altogether.
Wow.
So things were very fragmented. That's just the tip of the iceberg. And obviously, the old infrastructure was also not architected to merge everything together to present a seamless whole. And in addition, it was not architected for today's environment where teleradiology, remote work, it was very important. The other part of it is also that with all the silos, with it came additional IT support issues, because when you have 10 different applications, that's 10 more things that could go wrong at any time. And you're multiplying the chance of failure by 10, even if, everything was similarly reliable. So those were some of the big parts.
That it seems like a situation like that would create friction. I mean, not disagreement, but just friction in terms of between departments and between modalities and different kinds of clinicians. I mean, were you guys having trouble communicating because of these different silos that were in place?
Yeah, certainly. I think so, because the interfaces that we used were completely different. So what I saw was different from what Dr. Jansujwicz saw. And likewise for someone in OB, and then we didn't have POCUS or some of the other modalities we have now, but when you had to deal with a different interface altogether, different application, and things couldn't, communicate between each silo, that's where we ran into issues. For instance, as a radiologist, One example I like to give is that when I read a chest CT and one of the priors, the only prior might be a cardiac CTA that was done 2 years back, I see a lung nodule. And in the past, it was hard for me to pull up that prior CTA, cardiac CTA, and that nodule might have been there, but I'm stuck recommending a follow-up, and we end up having to do extra imaging, more radiation for the patient, and that's just, suboptimal care.
Yeah. Dr. Jansujwicz, you're a cardiologist. Can you tell us what was it like on the cardiology side with this kind of fragmented system?
Yeah, so in the past, if I wanted to read a CT or review a CT or some other more typical radiology modality, I'd have to leave my cardiology workspace and go into a separate radiology space. And so it was much less smooth, and the older systems, frankly, were much less reliable. So in our current setting, we have a incredibly reliable system. I can come in the morning and expect it to be up and running. I can have a day with, potentially up to 40, 50 echoes that I might be responsible for. I might have 3 to 4 to 5 CTAs that I'm also reading that day, maybe 10 nuclear studies. All those things flow seamlessly into my current environment, whereas in the past, things were, as Dr. Chng kind of noted, things had more seams and silos. And so now we're in one workspace with best-in-class connected applications within the EI framework.
That's awesome. Now, Stephanie, do you see, from the vendor side, you probably see a lot of this out there with a lot of sites that are still maintaining like separate data silos and that kind of thing.
Yeah, absolutely. I think the challenges that both physicians just mentioned are real. They're real challenges. And AGFA HealthCare had the thought process and the innovation about a decade ago to bring enterprise imaging to the market to solve those problems and to help with workflow inefficiencies that were created by those silos. And image accessibility is huge, and physician time is valuable. Treatment for patient care is expected to be immediate, if not, as fast as it can possibly be. And bringing all of those opportunities in together within one system is really what the thought process was for AGFA Healthcare. So it's really great to hear, from the physician perspective that that's come together.
For sure. Now, Dr. Chung, walk us through why you guys made the decision. Like, what was sort of the breaking point where you decided we've got to get rid of these data silos. We've got to go to an enterprise imaging management system that spans multiple disciplines, and kind of what were the things that you were looking for from a new system?
Certainly, one of the breaking points was really when the system started. When you get a critical point of data, you have enough studies, and volume of studies continues to increase, like everybody knows. And when you have to deal with it across, 5 or 10 different applications, the problems just multiply, and things can snowball. Obviously, our old system was getting unwieldy. It was getting slow, and the friction, as you mentioned, was increasing. Things couldn't get done. On top of that, reliability was also an issue because, as I said, when you have one of the 10 applications break down, then you've got a roadblock, hence more friction. So all those conspired together, and it was time. We all decided it was time to move to a more unified system. And I was involved in the RFP, and we visited RSNA. This was probably about 5 years ago now, 4 to 5 years ago. And we surveyed many major vendors with eye not only to the traditional radiology packs, but also with our colleagues in cardiology, and to make sure that we could extend this across the whole enterprise for future as more and more service lines came on board. And what we really liked about AGFA was some of the things that weren't apparent to me as a radiologist, but the IT leads, the PACS admins, carefully assessed the background infrastructure, the back-end infrastructure that AGFA had compared to some of our other competitors. And what we really loved was that there was no separate data store for cardiology and radiology. Everything was unified and treated equally, which is what we wanted. We didn't want to have any more hidden silos because some of the other competitors presented stuff as integrated, but in fact, in the background, they had different data silos for different things, which is not what we wanted.
Dr. Jansujwicz, what was cardiology looking for when you guys started this process, and like how closely did you work together?
Yeah, so I worked very closely with Dr. Chng. Cardiology was looking for a lot of the same things, but some slightly different things as well. And so, in the past, modalities like IVUS would not, so intravascular ultrasound would not easily flow into our prior PAC system, and now we could store those in a more efficient fashion. When we were going through the whole process of going from our old PACs to our new PACs, I think as Dr. Chng noted, we made some very important decisions to have a new archive, to have this system that's completely integrated in combination with that new archive. We made decisions together in our, if you will, our PACS governance group, where we decided how much information from the past would come over to our archive based upon regulatory as well as local factors. And we were able to accomplish all of that with our IT and AGFA partners. And I think that's an important point because anyone looking to kind of upgrade or change their PAC system, you have to think about what you have and where you're going. And so we carefully thought about all those things. And I think everything was really well orchestrated. And I think that shows up today in the fact that both Dr. Chng and I and our colleagues are happy in this environment. So it's not just the radiologists are happy. It's not just the cardiologists are happy. We even have vascular surgeons who are happy because their vascular lab reporting is easier than it used to be. And so we've been able to make a lot of people happy along the way by making important decisions within this unified environment.
Anything you ran into during that planning process that you weren't expecting that you had to you might advise people to plan for?
Yeah, so I think in the vascular lab space, that I think just in general, the vascular lab space is not as, I guess, maybe evolved as the cardiology space. And so there was definitely more work in the vascular lab space to get all the measurements, all these other pieces to the reporting software. So in that space, I think there was significantly more work. But when I talk to my vascular colleagues, they are thrilled now that we did a lot of that work to get to the point where reporting is easier for them. And I know vascular and radiology do work in some of the same space as well, just like cardiology and radiology work in the same space. And I think once again, everyone is pretty happy, and we're able to be in that one sandbox together and all have a toy that we're happy with.
Very good, very good. Now, Stephanie, at the end, we're gonna have everybody have a chance to give our audience tips on what to do. But was there anything in the planning process for implementing these kind of enterprise image management systems that you might advise people to really take a look at when they're getting ready to put out an RFP and look at vendors?
Yeah, absolutely. There's so many things. So I'll try to get the high points here. Technology is important, right? As Dr. Chng expressed, if you have a core consolidated platform solution that silos various other solutions, there's a lot of benefit there, right? It's managing one system versus managing multiple. But On the clinical side, there are things such as Dr. Jankowicz mentioned, from a vascular perspective, measurement mapping is a huge undertaking, a huge project, and it is kind of the Wild West, right? It's not as standard for measurements when it comes to vascular studies as it is echo studies. So, what AGFA is here to do is to help be consultative and bring up those things that we've taken from previous experiences and learned from, and bring that to our net new customers moving forward to make their experience that much easier with implementation, configuration, training of the system, adoption of the system. I mean, we could go a million different directions here, but I think just being able to have a trusted partner that really can be consultative with you to understand what are your current challenges and where are you going and how do we get there, and make that plan together.
Oh, very good. I'd like to remind our audience that we will be having, we'll be taking your questions at the end of our panel discussion. Please use the Q&A button at the bottom of your screen, and we'll get those questions in the queue. Now, Dr. Jansujwicz, let's talk a little bit about how much efficiency you're gaining through this integrated system. Can you talk about how it's benefiting cardiology?
Yes, so great point on the efficiency. So let's say that but tomorrow I'm going to go in and be the echo reader for the hospital, but I can also be the CT reader all in one space. Theoretically, if I had MRI skills, we have Circle MRI integrated with EI, and so I could theoretically read cardiac MRIs as well, all in that kind of same workflow, if you will. I'd be going in and out, through the different pieces, if you will, of EI. So these best-in-class applications that, really AGFA brought into EI so that we could all work to our fullest. So I think that keeps me efficient, being able to switch between modalities really easily, bring up those applications to read a coronary CTA, for one of my colleagues to read a cardiac MRI. We can do all of that within one workspace. And so I think that makes a huge difference. If I need to make measurements within echo, ComTech is pretty efficient within the EI environment. So let's say for new diastology guidelines, I want to do a left atrial strain measurement. I can quickly do that within the ComTech environment. And that's something that I can't even imagine having been able to do that 10 years ago in such a kind of quick and easy manner. So I can use the tools that are there in an efficient manner to continue to read at the speed I need to read at in a busy tertiary care environment, but I can do some of the extra add-ons as well to get some other data pieces because the tools are that good.
Wow. Dr. Chng, what kind of efficiency gains are you seeing on the radiology side from this integrated system?
Yeah, definitely. Huge. Efficiency is one of my passions that I like to work on to improve, in our practice. So with AGFA EI, this is an anecdote I like to tell people. Radiologists tend to almost never say good things about anything. They like to complain. I don't know. Cardiologists are a lot.
I think we're all like that. A little bit.
But you never heard anything from our radiologists other than, this is slow, this doesn't work. Within the first 2 months of go live, I had 5 different on-site rads and tele-rads come up to me unprompted and say, Yeang, this has changed my life. This is really,
Wow.
My workday is so much better. One of the big examples that I like to, talk about is with PET CT. Before we would have to go to a different application to read, and we are pretty PET heavy. We have a cancer center which churns out a good number of PETs, and there are also cardiac PETs that get done from Dr. Jansuwicz's side. And before we would have to go to a different application, different mouse clicks, different shortcuts. The windows look different. Even the way you scrolled the image was different. You wanted to pull up a old CT or ultrasound to compare, you couldn't do it because it wasn't on that application, right?
Oh, wow. Yeah.
So you'd have to go back to PACS. and then switch your mind again to the different set of shortcuts, the different windows, the different command keys that you would need to sort of and all that just resulted in a huge drag in efficiency, going back and forth, switching your paradigm every time you went back and forth. Just killed our efficiency. And now everything is read in EI natively for pets. That was one of our big things, and the pet readers have been really pleased with this. They just love being able to read in EI, and our pet volume has continued to increase, and we have more than kept up because of the efficiency that AGFA EI has brought us. And the other example would be a 3D mammo. Before we would have to go to a separate workstation. And now this morning I read 50 screening mammos pretty quickly at home using AGFA EI because the speed is amazing. I can read 3D mammos at home with no issues at all because of the speed. And I read it natively. Again, same application, same shortcuts, same commands, same way to scroll. Minor things, but it adds up to a huge efficiency loss if you don't have those.
And that's also going to help a lot in terms of training.
Absolutely. I
Training
think
is a lot more efficient.
Yeah, because you don't have to train across 10 different applications. Now you're just training one, and that was one of the things that we did learn during Go Live, that AGFA actually provided a lot of excellent training. But that, I think, is a key, no matter what you are looking for our listeners, when you go out there and make sure that the training is sufficient, because now you're putting all your eggs into one basket. You better make sure that your clinicians, your radiologists, your cardiologists, your techs get the training they need to do it well. And the nice thing about having one unified system is that you can focus all your resources to that one system.
Now, Stephanie, are you seeing these kind of efficiency gains at other clients besides Northern Health? And a second part of the question is, like, the training probably is easier for you guys as well, right? Only having to train your customers on a single interface.
Yeah, absolutely. I mean, it's definitely, as being part of the vendor side, it's music to my ears to hear and see how the vision and the planning and the innovation that AGFA Healthcare was able to, have the foresight to do and bring that to market. It's seeing that come to fruition is just amazing to hear. And yes, we are seeing that across our customer install base with those proven efficiencies, with ease of accessibility of imaging, easier workflows because they don't have to jump into multiple systems or go to certain workstations for certain types of functionality that they need. Having it all in one cockpit, if you will, is exactly what the vision was. From a training perspective, absolutely. AGFA Healthcare went with the innovation of coming up with a true core consolidated platform, because not only was it identified from a customer in the healthcare organization perspective, but internally we had our own challenges with multiple development teams, multiple systems that we were having to integrate, multiple things to train on. So it's also improved our efficiencies from the vendor side running our business by having trainers that can train one core platform, as opposed to learning various systems and applications just as much as the physicians are seeing it and feeling it. We were feeling that on the vendor side as well. So
That's going to be a huge benefit. Yeah. Dr. Chung, can you talk about the importance of image accessibility and like cross-department collaboration within the Northern Light system, and how much has that benefited from this new or from your enterprise image management system now?
Yeah, pleased to address that. One of the things that we started doing not long after we went live was that we strengthened our collaboration between the radiology and cardiology departments. Before, the cardiology department had a system when they were reading cardiac CTs and MRIs, they would send out the reads for the non-cardiology stuff, the lung nodules, the incidental masses, the liver lesions that you would see in the corner, to outside radiology group because it was so hard to cross that silo. But now, we work in the same system. So it's same images, same front end, the techs are seeing the same thing. And so now it is very easy for Dr. Jansujwicz to read a cardiac CT, send that to me to read all of the non-cardiac stuff outside of the heart. And we do that regularly. We probably read maybe, 9 to 10 cases or more a day between CT and MRI. Actually, probably more than that when you add MRI. And it's very seamless because now we live in the same sandbox, as you say. So that was one example. The other example that is great is that it's not just us. It's, from the clinician side, there has been more adoption and more active use of imaging from orthopedic surgery, neurosurgery. All the oncologists, are very heavy imaging users. And that comes back to the zero footprint viewer that AGFA has called Zero, that is embedded in our Cerner EMR. So it's very easy to bring that up. And the amount of tools that are available in Zero are actually very close to what we have in the full-featured desktop client. I remember showing a oncologist once that, soon after go live was like, hey, you can measure SUVs yourself. And they were like, what? We can do that? On the Zero footprint viewer? I was like, yeah, sure. Here's the option. And they're like, wow. So that's an example of them, being able to verify things. And before they would have to call radiology and say, hey, are you sure that SUV was correct? Like, this lesion looks bigger and hotter to me. So that's some examples.
Dr. Jansujwicz, does that kind of track with your experience?
Yeah, it's a great point. So our collaboration has improved because of this whole process, and it's two-part. It's not only the unified system, but it's also the governance piece and collaborating with your colleagues and cooperating with your colleagues and having strong administrative support as well. We have good administrative leads in the PAC space, good IT partners in the PAC space. And we not only provide the PAC system for Northern Light Health, so other small hospitals in the region utilize our PAC system for storage. And that helps me as a clinician because I can read some of those studies from outside institutions that aren't part of Northern Light Health. That's good for our institution and our patients. And if they go to one of those hospitals and get an echo or something there, I don't have to repeat it when they come here in transfer to the tertiary care center. I can access that image. And so, collaboration with radiology and with others and with good governance, incredibly important. It is so nice for me to be able to read a coronary CTA and not have to worry that I'm missing a small nodule. I can pick up big nodules. Don't laugh, Dr. Chng. I can pick up other things as well, but I'm going to miss things clearly that he is going to see because that is just, lung field, soft tissue. That is not my educated space. But in the coronary piece, I feel very comfortable there. And so having a good relationship, good communication, and, I'm able to start the report. And that's an important point. Like in cardiology, we use a lot of Ascend reporting for echo, nuke in those spaces, as well as cath lab. But for CT and MRI, we're in the fluency for imaging space. And I can start an FFI document, and then I send it for overread to Dr. Chng, and he does an overread and puts in his radiologist soft tissue report. And we're able to do that within this system very seamlessly. So going back again, we're not in silos, we're working together. I can feel very comfortable that I might have missed something, but I know he's not going to miss something in the soft tissue space.
Very good. Now, Stephanie, let's talk a little bit about the benefits of this for sonographers and technologists. Now, you're a current or former sonographer. What kind of benefits for these professionals do you see from using an integrated enterprise image management system that spans both disciplines?
Yeah, absolutely. I think both physicians hit on great points from that perspective. But from a sonographer perspective, if I'm getting ready to go scan my patient and they have a history of, rich abnormalities or anomalies that maybe aren't identified from cardiology, but it was an incidental found in radiology, et cetera, that just gives me that same image accessibility, that ease of using a core consolidated platform that I don't have to go log into another system, remember passwords, remember how to open and be trained on 2 different systems. It's just all there. So from an efficiency perspective, even at the acquisition phase, it's giving your technologists, your sonographers, the ability to view those cross-departmental imaging studies that are needed to help them ensure that they're doing their acquisition to the best of their ability. From the zero viewer perspective and integrating that into the EMR, again, gives your referring physicians, your clinicians, your physicians on the floors helping treat patients quick, easy access to everything all within one system. And the tools, as Dr. Chung said, the tools to be able to remeasure something quickly if they want and not have to call the department or call the radiologist or call the cardiologist to do something. They have those tools at their fingertips. So I think just across the enterprise, it really helps with every role and every persona have the tools that they need available to do their job the most efficient way possible.
Perfect. Like to remind everybody, we will be taking questions from the audience after our panel discussions. Please use the Q&A button at the bottom of your screen. Now, Dr. Jansujwicz, a couple folks on the panel today have mentioned integration with EHR and by extension, the sort of the longitudinal patient record. Can you talk a little bit about enterprise imaging's value to clinicians in that scenario?
Yeah, so I think there's a few value points there. So one value point is, so when let's say I'm the physician in charge of consults, one of the two is doing consults in the hospital, and I'm seeing patients with our APP group. They're presenting to me about the patient. I am bringing up the imaging within the Cerner EMR using Zero Viewer, as Dr. Chung noted. So I am just clicking an image link, and it brings that image up in our internet browser. And then not only can I see that image and go through that, let's say, echocardiogram, for that patient now, I have access to their other studies in Zero. So with one click, I bring up a table of contents and I scroll down, and I can bring up their CT to look for the CT of their chest to look for coronary calcium to see if they have coronary disease that no one's documented before. I can bring up an old echo to look at differences. Um, One important thing that I know I'm getting off the EHR piece, but within within EI, if I bring up an echocardiogram to read and I want to bring up the last echo to not just look at the report and compare to the report, but compare to images, incredibly easy. To double click, and now both studies are up, and I just click back and forth to go between the studies. So, you know, comparison is easy. Flipping through studies while I'm seeing a patient on the floor is easy. And then in the office, we still have human scribes with us in the office at this point. We are in a process. There's a partial transition. Some of us are using more AI related scribe technology. Some are still using human scribe technology. But I bring my laptop in when I see patients, and I will go into the EHR. I will click on the image link, and I will show a patient their mitral valve prolapse. I'll show them their coronary calcium. Because I think sometimes a picture tells 1,000 words, a video tells 10,000 words. And I think it resonates, especially with our more sophisticated patients now. They like to see their imaging.
Yeah, patients are coming in with all kinds of stuff. They're out there doing their own research. Well, we're going to start questions in a minute, but Stephanie, can you talk about what you see as the broader impact of enterprise imaging and kind of your future vision for that?
Yeah, absolutely. I think the broader impact of enterprise imaging is really much bigger than just consolidating systems. We've talked about the technology and how important that is, but it's also about creating that connected clinical experience where imaging is really easier to access and share for everybody in the healthcare organization. I think when radiology and cardiology do break down those silos and begin working together in a cross collaboration manner, it just improves that efficiency and patient care experience. And I think as far as the future goes, I think the future of enterprise imaging is certainly centered around cloud and SaaS strategies that improve scalability, accessibility, operational performance. I can go on and on there across the enterprise, right? But equally important is having a partner and not just a vendor. It's more than just the implementation and the go live. It is the sustained clinical care and outcomes and adoptions that ultimately just results in better patient care.
Yeah, for sure. All right. So we're going to start questions in just a minute. Q&A button at the bottom of your screen there. But I'd like to give everybody on the panel a chance to maybe offer some advice, some wisdom from your experiences in moving away from these separate silos for medical image management and into a integrated enterprise image management system. Dr. Chng, what kind of advice do you have for other facilities that are like looking to make the move that Northern Light did?
Definitely. It's funny that no one has said those two letters so far, A and I, which everyone cannot seem to stop talking about everywhere outside of. But one thing to consider is that, in our past system where everything was siloed and everything was fragmented between, different data stores and different applications, in the future, you can envision that there would be an AI system that would trawl through all of the patient's past records and try to uncover a unifying, all these different problems across, their cardiology imaging, maybe their dermatology, their pathology, and come up with a rare syndrome that might be invisible to each of the people who are looking at the individual silos. Without an integrated system like what we have now, that's not possible. So that's one thing to consider. Anything that requires work on the entirety of the patient's imaging history requires something like this. The second piece of advice, Dr. Jansujwicz has brought up the point of governance, and that's super important, I think, because now not only, I think, doctors are always used to getting their own way. This is the way I want it. But now you're bringing in several service lines, and you have to be able to, find and consider everyone else's needs, not just radiology alone, but now I have to, talk to Dr. Jansujwicz and his colleagues and see, what works for you. And that all comes back to governance. So having an effective governance platform and collegial way to mediate what everyone's needs are is paramount. The third thing that I'm just going to bring up that advice. We talk about efficiency. We talk about ease of collaboration and all that. All that you can throw all that out the window if whatever solution you have does not have two things: speed and reliability. If your system goes down for an hour every day, it can be the most efficient system in the world. You've lost an hour working time. You've thrown all that away. We've been live with AGFA EI for 3 years now, and we've had 0 unscheduled downtimes, 0, which is fantastic. Like it's unbelievable. You come in and we've had other systems go down. We've had our EMR go down. We've had, various other things around AGFA go down. AGFA just keeps going, and you just take that for granted. But, throw in an hour of downtime and you're so far behind. And the speed part I've already talked about. So,
Yep, for sure. Dr. Jansujwicz, what advice would you have?
So number one, decide what you want to be, what you want. If you want to have an integrated imaging system with collegial partners, create that governance as we've both talked about, get the right people in the room. You need administrative colleagues, you need physician colleagues, you need IT colleagues, you need the people who actually deliver the imaging care as well, whether it's sonographers, RTs, et cetera. But you need a group of people that can talk and can work together. And not everyone gets exactly what they want, but with EI, you all get a lot of what you want, and you can all use it. So that's number one. Once you've done that, decide on your workflows, make sure that you set up education correctly early on. And it's not just about, and this is a key point, it's not just about educating the radiologist, cardiologist, vascular surgeons who might be reading in the vascular space. You need to educate your colleagues who are heavy PACS users as well. So neurosurgeons, maybe urologists, others who are ER docs, who orthopedic physicians who are really in that image space. They need the education and training up front as well, and make sure that you have a plan for that. And then lastly, make sure you keep this engaged environment together. You're not going to have everyone engaged forever, but you have to have a core group engaged together. That includes the vendor, and we have excellent vendor engagement. And that includes radiologists, cardiologists, and whatever other mix that you have in your imaging environment at your health system. And I think those are really the key things. And some of my informatics mentors really taught me to focus on governance training and finding the right product. It's people, process, and technology, and that always holds in everything I've done in this space.
Yeah, governance is one thing that it seems to me is just really overlooked. Stephanie, what kind of advice would you have for somebody that's thinking about adopting an integrated enterprise image management system?
Absolutely. I think if you are looking for a true enterprise core single platform solution, make sure you do your due diligence because there are many vendors out there who will market a consolidated enterprise solution, but on the back end, as Dr. Chung said earlier, there's still just really multiple systems that are integrated together on the back end. From a governance perspective, you couldn't have said it better, Dr. Jankowicz. I think that bringing the right people to have a seat at the table, to be involved in the implementation, the configuration, and the training plan that is, sufficient for their departments and for their specialties is very important. Oftentimes it's not enough attention to detail in how we're going to train, how we're going to implement, and how we're going to support long term. Find a partner that has a plan and has continual care that can be, beyond just the implementation and the go live, but to support you throughout the years to come.
All right, very good. Great advice. All right, so we do have about 15 minutes left for questions. We got a lot of great questions that came in, so I'm just gonna fire away. This is for Dr. Chung. Any experiences with the workflow orchestration module that you can share? And Tony would like to know.
Thanks, Tony. It's funny you asked about that because that's the next thing that we are looking forward to. We are slated to upgrade to 8.4 of enterprise imaging, and with that is due to come on board Workflow Orchestrator. I've heard a lot about it. I've seen examples in production, but we don't have it live at our site yet. We anticipate it will be going live in a couple months, so check in with me then.
All right, very good. This is a question from Michael for Dr. Jansujwicz. Were the pieces you mentioned you would navigate from within EI accessible as integrations, buttons located within EI on the toolbar that allowed you to access those other pieces while still reporting within EI with the associated dictation software?
Yeah, great question. So TomTech is directly within EI, and so when I'm doing echo measurements, things like that, that's right within my EI space. And then in terms of nuclear, let's say in VIA, when I open up my nuclear reading software, that's right within the EI environment as well. So those are two great examples. When I open those up, it's right within EI, and then Ascend opens up reporting at that same time. So everything's right there within that environment. We have a Siemens scanner for our coronary CTA dual source, and we have some Siemens software that goes along with that. So for coronary CTA, I do read outside of the EI environment, if you will. So I open up a separate application. But that's in my workflow. That's really the only instance where I'm outside of EI for any particular time. We also have Terra Recon that is part of our EI environment. And my colleagues at two of the other hospitals who read CCTA read within the Terra Recon environment. And so that is just one area where we're a little outside maybe the all-in-one workflow, but otherwise in cardiology, I'd say we're mostly within that all-in-one workflow. I don't know if Stephanie, if you want to comment on any of that, just that I may have missed a technical aspect or two there.
No, yeah, that's okay. I'd love to pipe in. From an integration perspective, we do have different levels of integration. The Tontec and the NVIA that Dr. Jankowicz mentioned are embedded at a code level within our application, meaning the moment he opens a study, he's going to get the viewer resulted for that software automatically. That's just part of our smart hanging protocol technology and how we've integrated. For other best of breed things that are out there, you're going to need them. There's Circle, there's Terra Recon, there's 3Mencio, there's so many. We do desktop integrations where you do hit a button and that just launches that new window to that application in context. So there's a number of different workflows, but again, the idea is just to have that. You don't have to get up and swivel your chair and go to a different workstation, go to a different department. It's all accessible through the enterprise imaging application.
Yeah, and I
Good.
can chime in on that as well briefly. You know, the hanging protocol part, where how these integrations work, where it just shows up in the viewport in EI as just another viewport is key, because even though you have the power of the best of breed at your fingertips, you're really able to, let's say, go to another viewport and pull up a prior exactly like the way you used to, you know, in the same system. Very, very different than opening another application. You know, I can't overstate this. And all this is done by the smart hanging protocols, which in my book is one of the most powerful things on the radiology side in AGFA.
I had to learn what a
Question.
hanging protocol was, Brian. There was a cardiology, radiology husband-wife team here when we went live, and he was the one. So the cardiologist who was married to the radiologist had to explain to us this whole hanging protocol thing to the rest of the cardiologists.
Yes.
Yeah, it is a mystery, but once you get it solved, it's good to have. Question for Stephanie. What does AGFA have to offer? This is from Lelaine. What does AGFA have to offer to startup teleradiology groups, particularly regarding integration with EMR?
Yeah, no, that's a great question. Teleradiology is what we consider our M10 market. It is a new market that AGFA is going after. And I think with our enterprise imaging solution, our federated views, our workflow orchestration, hanging protocols, ability to read remotely, all of that plays into exactly what the M10 market is needing. I think that there's a number of different offline conversations that we can have that would go a multitude of directions, but happy to have those conversations, as we can.
All right, very good. Another kind of related question is, what are your experiences using enterprise imaging remotely? Dr. Chung, you did address a little bit of this earlier, but maybe if you can speak to that in a little more detail.
Yeah, no, definitely. It's kind of mind blowing, actually. I opened a HIT CT on airline Wi-Fi when I was flying over the Atlantic.
Wow,
And
amazing.
I did make sure that I was hiding the PHI. So I was facing,
Yeah.
I had it facing the window, and I was in the window seat, but I was blown away that the head CT opened just about as fast as it would have on site with our old solution. And this
That's
was
amazing.
thousands of miles away. The latency, for those of you who know, latency is a big component of PACS response speed, and the latency was over 2,000 milliseconds, 2-second latency. And it opened, and I was like, I could read on this plane if I needed to with in-flight Wi-Fi. We have probably about 30 teleradiologists all across the U.S. We are based in Maine, so we're on one end. We have several radiologists who are based on the West Coast. Speed is never anything they complain about. In fact, they comment on how fast things are. And it's just one of those things that we take for granted. No one complains about it, and it's just taken for granted that when you click on something, it just opens. And, as I mentioned, I read 50 screening memos this morning before the webinar from home, and they opened just as fast as in the hospital.
And Dr. Jansujwicz, you mentioned before the webinar started that you read some echoes at home last night, right?
Yeah, so I was on call last night, Brian, and early on there was a couple patients who had stat echoes. And so when I'm at home, I open up, I'm on a VPN. I'll open up on Zero Workflow, which is a web-based version that allows you not only to view the images, but it automatically opens up the Ascend reporting software as well. So I can read the echocardiogram from home, and then I can actually report on it and get that all done kind of in real time, if you will. So that was early in the call. Later on in the call, there was a patient who'd come in with a late presentation, anterior STEMI, so big bad heart attack, because he was having post-infarct angina, even though it was late presentation, had a percutaneous coronary intervention. ST segments never got better on the ECG because it ended up being a late intervention. That patient had some pain last night. They called me. I was able to kind of go through the images. I brought the patient up in the EMR, quickly went through the images, looked at the scenario, looked at the echo and the cardiac cap in Zero Viewer. And then I looked at the ECG, et cetera, and Cerner, and I was able to kind of make my decisions from home about kind of what was going on. And I think that's a powerful example for those of us who are still taking call at home, et cetera, on how you can manage a fairly complex patient, look at multimodality imaging with reliability, and make the decisions you need to make.
Very good. A question here from Jay on downtime, and I'm going to direct this to Dr. Chng. And Jay says, we strongly value 100% uptime, but realize that may not be possible. And what Jay would like to know is, how does your workflow change in the event that there is some downtime, and how do you find clinical support for these instances?
That's a good question to answer because, as I mentioned, we have not had any unscheduled downtimes, but we do have contingency plans. So, once a quarter, there is a scheduled downtime. It is usually scheduled at a time where, almost very little work is being done. And in most cases, it is about 10-minute downtime that is scheduled every quarter just to reboot servers and refresh the Oracle database, things like that. There is a aux server that is a system that would allow us to continue to work if there was extended downtime. I think, Stephanie, you can chime in later about that. And it is also, a choice of the institution. If you want to implement complete high availability, where you have two completely separate systems on at any given time, and you can switch over, that is a decision that the institution needs to make. But obviously, that requires more financial, resources to implement. And so far, we have not needed that in the last 3 years. The uptime has been amazing.
We have downtime protocols in cardiology, and I can't really remember them because we really don't use them at this point. The only time that we had a downtime that was unplanned, it was not EI, it was Ascend, and it was because we did a edit. We did a KB edit, so the database edit, and we did something incorrectly on our end, and so we caused our own Ascend downtime. It wasn't a vendor specific issue. So that I remember well, and we're much more careful in that space now. But yeah, we have all these downtime protocols that include potentially even going into old school dictation, which we try not to do because, all these processes now, when I read a study and the EMR is expecting to get, because the way the order triggers all those things, the EMR is expecting to get that study back. And if if that doesn't happen and you do a dictation instead, it does mess up processes behind the scene. And so not having these downtimes keeps everything more efficient and slick and avoids confusion. So reliability has been key. And frankly, from a cardiology standpoint, you want all the good tools. You want to be able to store all your image types, which we are. But you also want everything to be up and running all the time.
Question from Benjamin related to Ascend. How well does the Ascend software package work with AGFA EI right now?
Yeah, so AGFA EI and Ascend, I think, work extraordinarily well together. So we can select, like, we just had a discussion within our cardiology group about what data points from Echo that we want to automatically flow over into our Ascend reports. We had a much larger data set that would flow over into the reports, and we decided we did not want as much clutter. And so we were able to easily kind of make those changes within our AGFA to Ascend channel, if you will, there. So that interface. And so I think overall it's pretty easy to, decide you want to change something and you want certain things to flow, and you can get those measurements to flow over into Ascend. As Stephanie noted, within the cardiology space, I think there's a rich history there, and there's been a lot of evolution. And so the reports are very good at collecting the data from your echo machines, from your nuclear cameras, and all that data collects in a reliable way.
Very good. All right. We are almost at time. I do have one last question. I'd like to direct this to Dr. Chng. It's from John. Reflecting on the go live phase, how would you evaluate the initial rollout from a user adoption standpoint? What was the biggest stressor or bottleneck for the radiologist, and what did you learn from it?
It's a good question, John. I think there's always a lot of anxiety from longtime radiologists when you have been on one system for 10, 20 years, despite incremental upgrades on the other system, to move to a new system, new paradigm. And one very important thing that AGFA allowed us to do, which is very key for us, is that we had a test server populated with enough test studies that we got set up at home on people's home workstations. And we said, in the 2 months before go live, we said, here's your blogging, here's a password, go play, and no matter how much training you get or give, really what radiologists and cardiologists need is hands-on time. You can sit through a 12-hour class, but without playing with it yourself, the anxiety is still there because it's new. It's like watching a lecture on about driving a car versus driving it yourself, right? Or riding a bicycle. So that was key. Having someone who, like myself and Dr. Jansujwicz, who were champions before go live, who were deeply integrated with AGFA and, who knew what was going on. And that is also very, very important because, I managed to do a little bit of training ahead of time with certain radiologists who were very tech phobic. I said, look, let's sit down together. Let's go through this. And go live was, I think it took about 2 weeks for people to work through. I mean, nothing's immediate, but at least I would say at most within 2 weeks, we were back to our baseline productivity, if not higher, because of all the efficiency.
That's great. Good. Perfect. Good. Well, we are now at time. I'd like to thank everybody out there watching. Thank you so much for tuning in. I'd like to thank Dr. Alan Jansujwicz of Northern Light Health, Dr. Yeang Chng of Spectrum Healthcare Partners in Northern Light Health, and Stephanie Bazinet of AGFA HealthCare. Everybody, fascinating discussion. I really enjoyed talking to you all.
Thank you.
Thanks, Brian.
Thank you very much, Brian.
All right, signing off for the Imaging Wire. My name is Brian Casey.